Good morning and welcome back to PI Today. I'm Dr. Nick Loloee, bringing you the latest and greatest in the personal injury world. Today, we're going to discuss traumatic brain injury and some of its effects and some of its treatments, and bringing you a great doctor who treats traumatic brain injuries. We're going to dive into the world of mental health and mental therapy, and how it's used to treat people affected with traumatic brain injury due to a personal injury. So without further ado, I'd like to introduce you guys to the world famous psychiatrist, Dr. Rod Amiri, MD. He is a colleague of mine. He's been a psychiatrist for many, many years, dealing with some really, really difficult patients. So, Dr. Amiri, welcome to the show of
Thank
PI
you, Dr.
Today.
Nick. Thank you for having me here today.
Of course, of course. So, Doctor, please tell us about yourself, your training, how long you've been doing this, and what are your thoughts about the patients you treat with traumatic brain injury?
Thank you so much. Yes, I'm a board-certified psychiatrist and addiction medicine specialist. I'm also a certified brain injury specialist. I've been in private practice for about 20 years. This July will be 20 years, and I've pretty much been seeing and treating patients with traumatic brain injuries, I want to say, since I started practicing, because there's always been an overlap between neuropsychiatry, that's when people have injuries neurologically that leads to psychiatric symptoms, so then they need help, and a lot of these folks have come my way for help over the years.
That's wonderful. And what are some of the symptoms and that these people present with? Because obviously, it's tough to get a blood test for mental health. So what are people looking for with these people who suffer with traumatic brain injury, and there is a stigma to it in a sense that some people don't believe them when this happens and their behavior changes. So what are some of the signs you're looking for when this happens?
So it's first important to note that the brain is only about 3 pounds. It's about 6 inches long, and it's mostly made out of fat. So it basically poses as a neurobiological risk for the development of psychiatric disorders, especially when there's a case of traumatic brain injury where, for example, in car accidents, there's typically the whiplash injury, which causes acceleration, deceleration type of injuries because of the movement of this mostly fat-like substance within a hard skull, and that in itself can cause a lot of injury. And it's very important for folks that have suffered traumatic brain injuries to be mindful that their symptoms can take even months or years to manifest. For example, with depression per se, the 12-month point prevalence, meaning the number of cases that exist for a 12-month period up to that point, is about 2 to 2.5 times higher as far as depression is concerned in folks with traumatic brain injury versus the general population. So there's a higher risk of developing depression per se. And other mental health disorders, for example, anxiety disorders is actually more commonly seen initially. There's a specific trauma stressor related disorder called PTSD, which can manifest typically in concussions, mild TBI, because a lot of times those folks, even if they lose consciousness a bit during the incident, they tend to remember what has happened to them, and that recollection of the memory of their accident or their fall can definitely lead to the development of PTSD down
Correct.
the line.
And to the people out there where we are such a society of, if I don't see it, I don't believe it, based on diagnostics. A lot of these patients come back and that do brain scans and CTs, and bleeds are less than 1% of traumatic brain injuries, and even some physicians, whether it be in the private sector or in the hospital sector, sometimes give them a clean bill of health and say, hey, there's nothing wrong with you. And these people are thinking, they're losing their minds. And I kind of want to know is what are your thoughts on that, and then what is the chemical changes that happens for these onsets of behavior changes that we see that people struggle to communicate, and they're always at a loss because their friends, their family, even their private physicians might not believe them. So what are some of the changes that we'd see?
So it's important to first note that a lot of times psychiatric disorders can happen in folks post TBI and people that never had family history or personal history of it. So the person will notice a definitely change in the way they are even operating, because depression in itself post TBI can have a very much of a negative effect on recovery, as well as cognition, and increase the risk of dementia down the line. So, as we both know, many times the imaging studies won't show any abnormalities. But it's important to note also that many times people can suffer post-TBI from a phenomenon known as a sononosia, which basically means that the person, because of the specific injury, and it's usually on the right side of the brain, the right frontal and parietal section of the brain, including the right orbital frontal cortex, can develop this lack of insight into their condition or a denial of their deficits. So many times it takes some time for them to even be aware, if that anosognosia even clears up, that they have a problem. But many times family members, loved ones will notice that the person's behavior, they're, suddenly they were the coolest cat in the neighborhood. Now they're getting irritable and upset over the smallest things. Those are all little signs for us to pick up on, because, as I mentioned, many times the imaging studies will be normal.
And does, like you said, post accident, can a TBI exacerbate? If somebody was suffering with slight depression, can the TBI exacerbate it and turn it into something more severe?
Of course, and the development of psychiatric disorders are even more common in folks that. So it depends on these main factors: severity of injury, location, of course, and I'll talk about location in a sec. Mechanism of the injury, where if you have diffuse axonal injury versus a penetrating injury, which is more focal and will cause focal symptoms, so to speak. Usually with penetrating injuries, which I honestly haven't seen one yet in my career, if it's specifically affecting the frontal lobes, the frontal lobe, it can lead to personality changes, irritability, impulsivity issues, where someone could have been a stand-up, debonair citizen of their community now is quite impulsive and disinhibited. So those are all changes that the person or the person's loved ones can also notice over time. But to answer your question, with depression per se, usually, believe it or not, it's more common in, again, depends on severity and location, but I've seen a lot of cases of depression secondary to TBI and folks that have had the diffuse axonal injuries, and where they've suffered from a whiplash injury, where there was acceleration and deceleration of the brain moving within the skull, which is, again, fatty brain moving in a hard skull. So, but the areas that with depression per se are mostly affected are the frontal limbic tracts. So we're talking about the prefrontal cortex, and then the limbic structures, which are specifically, I'm talking about the hippocampus and the amygdala, which control a lot of the hippocampus in particular, mood and memory, and in the case of the amygdala, fear, recognition of fear and threat, and anxiety as well. Also, injuries to the thalamus and the basal ganglion can also lead to the development of, in this case, depression and other psychiatric disorders.
And so there's chemical changes. Now, what do you do as far as for treatment goes? Because these people obviously are suffering, and they need something to balance them, I would imagine. So what is the course of treatment? I know all cases are not created equal, but some of the cases you've seen.
So what I always tell, and I've been using this analogy ad nauseum for years to explain to patients, in treating mental health disorders, it's like helping a super athlete. Amongst many things that super athlete has to have in place, they have to be on the right diet and have the right training. I'm not personally a pill pushing, pen happy doctor, but many times, especially when a person who's never had a history of mental health issues suddenly post TBI is suffering from depression. They can't get out of bed. They can't start their day. They've lost interest in things that they would normally enjoy. So this is where we have to go in and treat them like we would treat someone with primary depression, meaning someone who's had a history of it and it's not due to their TBI. So it would still be a combination of medication and therapy. There's a specific therapy that I think anyone in this millennium could take a course of it and benefit from it. It's called cognitive behavioral therapy. And it's this specific type of therapy is important because it helps the person who's in this depressed or anxious state get out of this mode of living subjectively, because depression and anxiety keeps the person hostage in this place in their mind where it's going to be all about what if this, what if that. If I can't do this, I can't do that. So there's a lot of that going on, as well as limitations that the person now has because of their injuries. They can't play with their kids anymore. They can't play the sport that they loved or do hobbies and activities that they were used to. So this type of therapy, cognitive behavioral therapy, helps a person realize how their thoughts, behaviors, and feelings are connected, and how to get more objective with what they're going through, including developing coping skills and coping mechanisms. Because now a lot of folks, when they suffer traumatic brain injury, they're at a point where it's quite alien to them.
Correct.
And it's very hard to acclimate to this new way of living.
And what are some of the medications that's in that you use to treat these things?
So it's still like the gold standard treatments don't change. Like, so still, if someone's presenting with a unipolar depressive disorder, meaning not a bipolar, and mania can also be a secondary to traumatic brain injury as well. Not that common, I must say. I did a little search of my patients in the past 4 or 5 years. I've probably had 4 or 5 cases, so about 1%. But it would still be the SSRIs, the selective serotonin reuptake inhibitors. And with brain injuries, it's like treating the children or the elderly. You want to start low with the dose, go slowly, but you want to treat, because the person will respond to the medication. And I've seen people that really felt despondent, and they thought that they can't get out of this hole because it's alien territory for them. They never knew what depression was or anxiety was, and now they're 45 and they can't get out of bed, or they're living in their minds. They can't leave their house. They're scared. They're fearful, and it really the medication can make a big impact on improving their symptoms. But then again, as I said, that athlete can't just be taking the diet and sitting home and playing video games. They have to use the diet to use the energy that they're getting from that diet to then go train. And that's where the CBT, the therapy, can be quite helpful.
Correct. And a lot of people cannot differentiate, or they don't know how to differentiate between psychiatry MD and psychology PhD. So they both treat traumatic brain injuries and behavioral and brain issues. Can you please outline for us what is the difference and how both professions can help simultaneously to treat a person suffering from a traumatic brain injury and depression?
So, in treating someone with traumatic brain injury, there always has to be a multidisciplinary approach. To answer your question, the difference between a psychiatrist and a psychologist is that a psychiatrist, like myself, goes to med school, go to medical school for 4 years, and the quintessential psychiatric residency is another 4 years. Whereas a psychologist, and there's different ways of achieving that status, can go the PhD route or a PsyD route, or even becoming a marriage and family therapist. And their focus is mostly on the training aspect, as I was saying, meds and training. I myself, currently I don't have the bandwidth to take on any more therapy patients, but I earlier in my career, I would see most of my patients both for med management and therapy. It has to be together, and it has to be, as I said, in treating, I have colleagues that are neurosurgeons, orthopedic surgeons, neuropsychologists that do all the hard work. They do the neuropsych evals for us.
Sure.
And we get all the nice results, and then we, depending on the evaluation, it helps us significantly, us meaning psychiatrists and neuropsychiatrists that are involved in the care of folks with traumatic brain injuries.
Correct. So basically, the talk therapy, in layman's terms, is very helpful when in conjunction with the chemistry changes and the med management that these patients need.
Yes, absolutely.
Okay.
And if you think about it, it's pretty common sense, because the meds will help, but they're not. Without the therapy, the person isn't. They don't have that component that helps them get objective. At the end of the day, it's about getting objective. What's within my control to make it easier for myself? What I can't do that I have to kind of let go or seek help otherwise for it. So it really helps the person, in a nutshell, and I'm going through layers of it, to really come to terms eventually and be able to have a meaningful, fruitful life post-injury.
Right. And we've had I've seen a quite number of patients and read reports obviously on it, that when they suffer from a big traumatic brain injury, it completely, in a sense, that their lifestyle, their routine completely changes, and it has great effects on their family, where somebody is like you said, an upstanding citizen, has a 9-to-5 job, they lose their job. They're married, they start being violent towards their spouse. These effects, how do you get them under control, and what duration of time is? And I know everybody is a specific case, every patient is different, but based on your experience, what is the term of the length of time to get these patients back to a level where they are dealing with a semi-normal life?
Well, as he said, it's really dependent on the person, the severity, the location of the injury, the psychosocial factors that are contributing. As I said, a person can realize that they have deficits, and that in itself, physical deficits, that in limitations, that in itself can make them depressed. So there's the in helping people with any psychiatric disorder, post-TBI or not, it's always about taking into account the biological factors, which pertain to genetics, injury, previous psychiatric history, psychological factors, the stress of what they're going through, and then social factors. Are they working? Did they lose their job? Do they have a support system? They have a church, a group that they belong to that could give them a sense of belonging and validation. So really, it's a hard question you're asking, because everyone is so different. With psychiatry, as I tell patients, there's no single blueprint that I can apply to everyone. But what I'm big on is educating. To me, the most powerful weapon isn't a nuclear missile, it's education. So I spend time educating not just the patient, but their loved ones. Because for them, they don't see any injury on the head, but they see that their loved one is misbehaving or is depressed all day and not getting out of the room, or having panic attacks every time they sit in a car and they don't know how to deal with it. So it takes time. Again, some people depends on the individual's resiliency. For example, if someone's more resilient and have support, and they're on the right treatment and they get in therapy, for sure they'll probably get to a point that they're a lot more stable sooner than later. But it's really a difficult question, because I've seen so many patients with various degrees of injury, severity-wise, and it's just it's very much case by case in that.
And some of these patients that obviously get on SSRIs have had a really bad traumatic brain injuries. I've seen them that, some of them are on these medications lifetime due to the traumatic brain injury, because some of them might have a permanent behavioral change, and these type of medications are helping them cope with their everyday life, because it's not like a wound that heals that you see, right? It's subjective and behavioral, and these medications might have to stay on these medications for the rest of their lives.
100%. And I'd always gear it this way. When I start someone on a medication, let's say post-TBI case of depression and generalized anxiety, we'll start low with the medication. I'd like to see them within 4 to 6 weeks of our first meeting. If we notice that the medication has made a major difference, let's say 70, 80% decrease in their symptoms, then I always think about the possibility that it's probably to this person's benefit to just stay on this medication for life, if it's made that big of a difference. The goal for me is still to see if I could taper them down and off, because I'm not pen happy or pill pushing. But this is where I have to also remind myself that there's no single blueprint. I'm just going to follow this patient a few times a year and make sure that they are doing just as well, and they feel happy and content with where their recovery and the abatement of their symptoms. And then we go from there. But yes, to answer your question, some people will end up spending the rest of their lives taking medication, but the pros in those folks are going to outweigh the cons of taking the medication a lot more.
Correct. And for those select patients that you mentioned, a small percentage that go towards the mania, the rage, the uncontrollable behaviors that is not in society's four walls. How do you treat those?
So a lot of times, again, when there's, for example, mania, which can be a result of, again, injury in the frontotemporal regions, and also when there's dysregulation of the dopaminergic pathways. That's too much dopamine can lead to mania and psychosis. So there's other medications like mood stabilizers that or dopamine serotonin modulators, such as aripiprazole or olanzapine, that I've used in patients with either mania or impulsivity. One medication that I've had a lot of success with in treating mania secondary to TBI, because usually the mania that results post-TBI is very much irritable, heightened mood, because mania can manifest not just as feeling happy and the person looking like they're on drugs, but they're not and they're way too happy. It could also present as feeling expansive, like talking a lot and being too full of oneself and coming off as being haughty and arrogant. But there's a third major way that mania can manifest, and that's heightened irritable mood, and that's what we mostly see post-TBI. So that's where a dopamine serotonin modulator or medication that I've had a lot of success with, it's called oxcarbazepine, trileptal. It's a anti-seizure medication by nature, which I found it to be very effective in quelling those type of impulsive, aggressive behaviors that can manifest post-TBI. Now, if there's no history of mania, an SSRI can help with that as well, because an SSRI can help with depression, anxiety, irritability, aggression, impulsivity. But it's very important for someone like myself to rule out the mania aspect, because if someone has underlying bipolar and you prescribe an SSRI, it actually can make matters worse and cause a paradoxical effect and either push them further into mania or now plunge them into even a suicidal depressive episode.
Well, that's a good point you brought up. When a patient becomes or has the symptoms or the behavior or the signs that they're suicidal, what parameters are around that? What signs should their family, their colleagues, what should they be looking for?
Well, if someone is expressing suicidal thoughts with or without intention, they have to see a doctor or go to the ER ASAP, because we never want to take any type of verbal communication of suicide lightly. So if someone is experiencing suicidal thoughts, and I'm a lot more conservative, whether they have an intent or plan to hurt themselves at that moment or not, it would be important to get them straight to their doctor. Now, if they have intent to plan to hurt themselves, that's where we got to take them to the ER or call 911, because you never want to take anything that a person says about suicide lightly.
Correct. Well, thank you very much, Dr. Amiri. Guys, there you have it. The insight into the brain and behavior of traumatic brain injury. Something that is a lot of times missed. And Dr. Amiri is an expert. And we thank you a lot for coming on this show, Dr. Amiri, and taking time on your Saturday morning. I know you're a busy guy. And ladies and gentlemen, that concludes our guest today on PI Today. Join us next week with a brand new doctor, and we'll be covering more diagnosis and treatment based on accidents that happen in the personal injury world. Thank you again. See you next week.